I now request Dr. Vijay Alexander from CMC Vellore to make his presentation.
Good morning to all. I'm grateful to the TIE NHM and the organizers for this opportunity. Over the next few minutes, I would like to briefly take you on how to predict response to therapy in patients with rodenticidal hepatotoxicity. Now, this includes patients who are undergoing standard medical therapy as well as patients who are undergoing plasma exchange. Next slide, please. So, we have already been through this. It's a highly toxic compound. Elemental phosphorus is the most common constituent. Occasionally, in fact, rarely we come across aluminum phosphide, zinc phosphide, and anticoagulant-based rodenticides. Ratol is the most common brand that we may end up seeing in and around Tamil Nadu. The next slide, please. By this, I just mean to say that it's quite unregulated and quite easily available. We can go on Amazon and buy a pack of 10, and it's quite cheap. Next slide. So toxicity in liver is delayed by 4 to 5 days most often. Occasionally we have earlier presentations or slightly later presentations as well. Now I have given a few definitions, and I think these definitions would come in handy as we listen to the rest of this talk and the subsequent talks as well. So by uncomplicated hepatitis, so this is in increasing severity of how the patient presents with regards to liver. By uncomplicated hepatitis, I mean that the patient presents with mild LFT derangement, maybe a slightly high bilirubin or slightly high, slight elevation of SGOT, SGPT, but otherwise the patient is well and there is no other organ involvement. Severe acute liver injury is where there is liver function abnormality as well as coagulopathy. So our INR starts going up. By definition, more than 1.5. Acute liver failure is when severe acute liver injury is along with that, we have onset of hepatic encephalopathy as well. Occasionally, we have extrahepatic manifestations as well, and cardiotoxicity is rare but deadly combination to have along with liver involvement. Next slide, please. So, what is the real problem here? So, when patients develop acute liver failure due to any etiology, and they satisfy the criteria which says they need a liver transplantation is the norm, and that is the standard of care worldwide. Now, the TNISG study highlights the need for non-transplant options for managing liver failure in Tamil Nadu. Dr. Eapen has already mentioned there are roughly about 1,000 liver transplants that happen in India, and most of these are LDLT or live donor liver transplants. Under 10%, so it's around 7.5% of these are for acute liver failure, while more than 90% is for decompensated cirrhosis and chronic conditions, HCC and such. So out of 1,000, we have about 50 or 75 livers going for acute liver failure, and we see that there is a gross mismatch between the demand and the need. Next slide, please. So clearly, there is a need for non-transplant treatment options, especially in resource-constrained settings, not just as a bridge to transplant, but we need standalone therapies which can improve survival in these patients. And this is where plasma exchange comes. Next slide. So this is a seminal study from Amrita Kochi, where rodenticidal hepatotoxicity patients who met listing criteria for urgent liver transplantation were looked at. I'll come to the listing criteria in the next slide, but I just want you to focus on the third column, which is the treatment column, where we see that 8 patients had standard medical care and none of them survived. So there was 100% mortality in that group. 14 patients required liver transplantation, of whom 12 were alive at discharge. Next slide. So what is this listing criteria that the study used? So this is MELD score. MELD is model for end-stage liver disease. Score more than or equal to 36. And so that's a very high MELD score we are talking about, and we are talking about significant liver damage. Or if the baseline INR is more than 6 and there is onset of hepatic encephalopathy. Now, I just want you to remember that this particular criteria predicts outcome with standard medical therapy. This does not include patients who are undergoing plasma exchange. Next slide. So, acute liver failure is a high short-term mortality illness. Overall, untreated can have poor prognosis. Now, early recognition of the syndrome and who develops significant toxicity is the most important thing in offering timely therapy and is key to obtaining favorable outcomes in these patients. Many prognostic models have been devised to describe the prognosis in these settings. Now, most of these are for selecting patients for liver transplantation, urgent liver transplantation in ALF. The most widely used criteria is King's College criteria. Next slide. So, King's College criteria was first published in 1989. So, it's quite old and it stood the test of time. And it is used to determine indicators of prognosis in patients with ALF. And it helps prioritize the need for liver transplantation in these patients with acute liver failure. It's further divided into patients who have ALF due to paracetamol and due to non-paracetamol. We will not go into details of the criteria per se. Next slide. Now, we have many more models for predicting survival in ALF. So, on the left column, we have static models, by which I mean it is a one time point assessment. And then we have dynamic models where we are assessing the patient both clinically and laboratory parameters at more than one time point. Serially, they are monitored. So, on the static group, we have King's College criteria, Clichy criteria, model for end-stage liver disease again, and Kochi criteria, which we just spoke about. Kochi criteria here is etiology specific and refers to rodenticidal hepatotoxicity alone. Alpha score, in fact, it's from AIIMS Delhi, and there is, it's a dynamic assessment of parameters at admission and day 3, and different parameters are looked at. Here, I just want to highlight that dynamic models are definitely superior to static models for predicting survival in ALF, because we are not looking at one time point, we are looking at more than one time point, and we have a trend of how things are progressing. Next slide, please. Now, before we go on to predicting survival, it's important to see and select who is the ideal patient for initiating PLEX. And this is where the concept of PLEX eligibility, or who is PLEX eligible, comes in. So, on the left hand side, we have indications for initiating PLEX, and I am referring to the TIE, NHM and the TNISD guidelines. On indications, we have if your INR is more than 4, if there is worsening, even if it is not more than 4, but on day 1 it is 1 and day 2 it is 3, or we have a serial worsening on monitoring. And third is onset of hepatic encephalopathy. Now, contraindications we can look at as relative contraindications and absolute no-no for PLEX. So, relative contraindications would be if there is active untreated sepsis, hemodynamic instability, by which I mean inotropic support or vasopressor support, and if they have had a recent bleed. An absolute contraindication as for transplant and any treatment option would be if there is irreversible brain damage, which can be indicated by anisocoria, decerebrate posturing. So, we are entering a territory of futility of care. So, then offering PLEX may not be a good choice here. Next slide, please. Now, how do we predict survival with PLEX? So, this is the key point of my talk. So, here we analyze patients of all age groups admitted with rodenticidal hepatotoxicity and Vellore over a 10-year period, and we had about 200 patients, of whom 114 were treated with plasma exchange. We aim to assess predictors of survival in patients treated with PLEX who were PLEX eligible. So, by PLEX eligible, I mean patients who had indications and who did not have contraindications, and then fulfill the Kochi criteria, which we just referred to. Next slide, please. So, I just want to draw your attention to, so overall we had about 32 patients who fulfilled this very selective selection criteria, both fulfilling the listing criteria as well as had indication and had no contraindication. So, 22 were alive and 10 were dead. In that, 2 parameters stood out. One was presence of hepatic encephalopathy, stood out as a significant factor on univariate analysis, and delta MELD. By delta MELD, so that's the second red box. By delta MELD, I mean between the first PLEX and the third PLEX, what was the percentage reduction in the MELD score, or the model for end-stage liver disease score. In patients who were alive, it was 44% reduction, whereas in people who did not survive, it was about 7% reduction. So, there was a significant difference. And from that, we got an adjusted odds ratio of 0.88, and this was statistically significant. Next slide, please. So, from this, we plotted an ROC curve, and we found that decline in MELD by more than 20% while undergoing PLEX had 90% sensitivity, 90% specificity in predicting 1 month survival. This had an adjusted odds ratio of 0.88, and the area under the curve was 0.93, which means it's very good. Next slide. I am just coming back to this slide again just to reiterate the point of who is PLEX eligible and who would be an optimal candidate for offering plasma exchange to. So, rodenticidal hepatotoxicity patients with ALI, that is acute liver injury or acute liver failure, who are not on inotropic support may be optimal candidates for plasma exchange. Now, going back to predicting survival, patients predicted not to respond to PLEX. That is, you don't have the 20% decline between day 1 and day 3. They may go on to need urgent liver transplantation. Clearly, they are a non-responder group. So, recognizing an earlier stage of the illness like ma'am just referred to may improve outcomes in these patients. Next slide. Now, why is hemodynamic instability such a concern in these patients? So, the concern raised is that they are already on vasopressor support, they are already hemodynamically compromised, and we are going to remove fluid and plasma from these patients, which can then further compromise their hemodynamic status. It can go on to cause worsening shock, it may cause renal dysfunction, so end organ damage like renal dysfunction, we do not know. That is one main concern here. Once the patient has gone on to develop multi-organ dysfunction, inotropic support, we know that they have poorer outcomes. So then the question is, are we already outside the window of benefit and are we too late in the game? Next slide. So in conclusion, from the data set that we have looked at, we now have a dynamic predictor of survival on PLEX, that is a delta decline between day 1 and day 3. If the MEL score reduces by more than 20%, we know that they are very, very likely to survive and will not need transplant. This helps early identification of responders and non-responders, and also it's important to identify this optimal window for PLEX so that we can improve our outcomes as well as optimize the manpower and the utilization of things that we use for plasma exchange. Thank you so much.
Thank you, Dr. Vijay. It was a wonderful presentation.